First, so it's the session is called 3 Hot Debates in HIV, and we launched this kind of session in 2 years ago, in 2012, and it was a success with a lot of blood. So we will try to do the same, and it's my pleasure and honor to co-chair this session with Dr. Alain Lafeuillade. And first, I think we are going to show you the mode d'emploi of the voting pads. Le mot-clé est mode d'emploi pour la régie, pareil. So it's quite simple. Next slide. Next slide. So we have 3 debates. No link between the 3 questions. The first question is, should we avoid protease inhibitors in first lines due to their lipid side effects? And in practice, you will vote first, then we will have the pro and the cons, and you will vote again to see if there is any impact of the debate on your mind. So, first vote. So it's simple, it's yes or no. The first answer is yes, we should avoid protease inhibitors. And the second answer is no, we still have to use protease inhibitors despite their side effects. And don't forget to press OK. 67, 70. Hurry up. Last night, you were more reactive than that because you had only 10 seconds to make your mind. So we can consider that your vote is finished, okay? So 43% adhere with what Jean-Pierre Routy will defend, and a small majority adhere with the opposite. So it's your role, Jean-Pierre, to inverse these results.
So thank you. So I have to make your mind. So next time you have to press 1 and say OK. So should we avoid protease inhibitor as first-line therapy due to lipid effects? Number 1. So atherosclerosis, coronary artery disease, very important, very common, and you know very well that all HIV, microbial translocation, inflammation increase the risk, early aging, you know all that. And if you give medication for HIV that increase lipids, triglyceride, of course, if you have a choice as a first line, you may choose another class of drugs. I'm still thankful to the protease inhibitor as a class for what this class did to my patient. PI are extremely effective art, no doubt, but metabolic syndrome, dyslipidemia, lipodystrophy, cardiovascular disease, and insulin resistance, and that was presented this morning at several times in this meeting. But don't forget, protease inhibitors are used with his friend, his stepping stone, called the ritonavir. And ritonavir, despite low dose use today, increase total cholesterol and LDH levels, and more than the NNRTI, increase HDL likely. Myocardial infarction is a risk and is not fully explained by the lipid change. So it can be a direct class effect due to, with the exception of reatase, as discussed this morning. So all PI, but maybe reatase, have additional bad effect on the heart independently of the lipids. And if you follow some literature, protease inhibitor disrupt lipid metabolism by activating endoplasmic reticulum stress, so that's the aging process, that's your mitochondria, inhibiting autophagy activity in your adipocyte, and you know that autophagy, when you use it, it's a kind of green system, it's a recuperation, so you can become a centenarial, you can come with age and not die young. So that's very important. There is an extra lipid effect. If you look last month, low density lipoprotein and ritonavir, there is a direct interaction between antiretroviral and lipids mediated by the P-glycoprotein, so another transporter and another effect directly linked to this class and certain of the members. So if you are a patient and you say, at my age, I want to avoid protease inhibitor because I was infected young and I want to go long the way. So you can choose to what you have, and you have integrase inhibitors. They come today with 3 different flavors, raltegravir twice a day, helicolavir boosted, and dolutegravir once a day. And you have a different pattern of drug resistance development, which is extremely rare, and extremely rare for the new one, the dolutegravir, who as presented by Mark Weinberg as a kind of magic bullet to avoid drug resistance development. So integrase inhibitor and inflammation, if you have a choice, you can pick 3 drugs, and they are associated as a class, as an alternative to PI, faster viral load decay, so that's very good, and patients are pleased, than PI and NRTI. CD4 in certain studies are higher on long term than comparator, generally Sustiva or protease inhibitor, and it's a lipid neutral, so it's good or it's not bad for your lipid. In addition, the integrase inhibitor may have benefits on inflammation. Inflammation depends, of course, on lipid, but there is an extra lipid effect, maybe like statin, and you know the US guideline for lipids have changed. There is no threshold to decrease HDL cholesterol or to increase, is to be on statin, because there is an extra lipid effect of statin, and probably integrase have this extra lipid effect. And because we are in France, I took a French slide from the famous ANRS, and at the time when people were switching T20, you know, the old injection for raltegravir, so it's not a protease, it's not a common drug, you can see you improve the IL-6, you improve the inflammation marker. So there may be a true anti-inflammatory of this class of drugs. Because we are in Europe, and vote is next Sunday, so Spiral with Dr. Gattel, what can we, so when we switch, and he did this very nice study 3 years ago, looking at different markers from inflammation, endothelial hypercoagulability, and a nice study, with very well-powered study. And you can see that the lipid, after the switch from protease to raltegravir, the anti-integrase class, improves the triglyceride, decrease the lipids. And if you look at the inflammation markers, they are quite low. And you know that C-reactive protein, IL-6, and D-dimer have been linked to death and to clinical event as a non-AIDS event, so it should be very good to have a low level of this marker. So it can be just the stopping of protease, or on top of that, the anti-inflammatory effect of the integrase class. Of course, you may argue that you need a prospective study to assess the protease inhibitor and the integrase, and you can see that olive oil also can decrease your lipid and increase your survival. So you saw this study this morning. If you compare what we do commonly, Reatase, Darunavir, and Raltegravir, so the most common use prescription, and you can see there is a good result. And what is important is that there is a better stable lipids with the raltegrative arm, not the other groups, and there is a better effect on the lipid in a face-to-face prospective study. Is not a single drug, is a class of two different drugs having cardiac effect or less cardiac effect according to that, and you can see that there is benefits in the lipid and maybe an additional anti-inflammatory effect of the protease on the integrase. So what to do? But it's quite easy. You have some guidelines. Pick up the good one. If you are a US citizen, you may follow the DHSS, and you can see in bold letters that the integrase inhibitor is flourishing, and it's a nice way to start, and that's a better outcome study we ever had, and that was even presented by François Raffi, so you should follow this path. And if you are in Quebec, the new guideline from last week, they're very fresh, they were nearly tailored for this meeting. You can see that we can use first line all the three integrase inhibitor as a commitment for the patient to welcome them in HIV treatment. And that's the member of the committee, including Mark Weinberg. And as a conclusion, to keep in time, to give a chance to my competitor, we have alternative to protease inhibitor like the integrase inhibitor, so use them first line. Better outcome as a class than other class, lipid friendly, reduction or maybe absence of increased inflammation. And remember, we had a session 2 minutes earlier, early and long-term lipid friendly, so early treatment is the best. And also physical fitness is also needed. That's my daughter. She finished fourth at a swimming competition in Mexico. So thank you.
Thank you. Now the opposite with a tiny advantage at the first vote will be presented by Hans-Jürgen Stellbrink. No, there are two presentations and we vote after.
So we're not going to have the vote now? We're not going to have the vote.
The menu, please. Maybe you should try escape.
Okay, so we're not going to have the vote now, is that right? I left the conclusion slide on for a minute because I wanted to convince you that everything was fine about Jean-Pierre Routy's presentation except for the conclusion slide. And I hope to convince you now. First, these are my disclosures. And I want to ask you, why should we avoid PIs in first line? Because they're really nasty drugs? Because they have any advantage, there's any advantage of using them is more than outweighed by PI-induced lipid increases? Are we sure this is the case? Or because other drugs achieve the same but are completely harmless? So let's jump into looking at the alternatives, because if you want to throw away a class of drugs from first line, you have to ask yourself which alternatives you have. If we look at the NNRTIs, we see, well, there is a similar lipid profile actually for efavirenz, increases of both LDL and HDL. Nevirapine has a somewhat better lipid profile, but significant toxicity, and this is why in the guidelines it's become an alternative more than in many guidelines rather than being preferred. Rilpivirine also has a better lipid profile, but somewhat weaker virological activity and is not licensed for people with greater than 100,000 viral load. So it's not a real alternative, an equivalent alternative. And about the INIs, we know, we've seen that raltegravir has a better lipid profile, but the disadvantage of being twice daily, which is a problem for many of my patients. Dolutegravir definitely could be a very clean drug, but still evidence has to accumulate for a little longer time than for the 96-week studies we have in our hands right now. And alvategravir actually has a similar lipid profile. And this is, for example, shown in this compiled analysis of the 102 and 103 studies. These are the cholesterol increases on Stribild, on Atripla, and on atazanavir plus Truvada. And you see all of them have these lipid increases. All of them have more or less some increase in LDL cholesterol, and the difference is mainly with regard to triglycerides. And there is another thing that is very important in this equation, that is, have the PIs got a selective advantage over other classes of compounds? This is just a compilation of a lot of phase 3 trials done. This is the year of licensure at clinicaltrials.gov. It's not the year of the start of the trial. Different analysis methods, no doubt, different ways of handling failure, and different interpretation methods. But what you can see is resistance was more frequent in earlier trials, at the end of failure, as the end result of virological failure. And it's always in the one-digit range of percentage. And it's gone down quite a lot in the recent trials, not only because the drugs became better, but also because we became better at excluding people due to their increased risk of failure. But the only thing that is really appears to be relatively clean in these studies is an arm containing a protease inhibitor, 0%. Plus, now in the first trial we've seen in the Flamingo trial, dolutegravir with no resistance. So there is quite an important advantage. And for me, I have to say, there's a bit provocative, in antiviral therapy, resistance development is comparable to a cardiovascular event in cardiology. It seriously limits the chances to obtain sustained viral suppression and thus to reach a normal life expectancy, and patients have to bear the consequences of resistance development lifelong. So it's always a balance between advantages and disadvantages, and you have to make up your mind which is more important in that patient for you. There's another aspect, that is, do we really understand what we are looking at when we see increased lipid values? This is data from the MAX cohort study in about 50 individuals in whom lipid values were known from before HIV infection. And you see, people had higher lipids before HIV infection. This is total cholesterol. The red one is HDL cholesterol. Higher lipid values before HIV infection. On untreated infection, they had lower cholesterol and a little bit lower HDL cholesterol levels. And on antiviral therapy, 4 different time points, they showed this increase. So what does it mean if we see an increase here from baseline? It could be partly a return to baseline phenomenon, and this person could have lived with an increased cholesterol already since his childhood. When you then calculate the magnitude of the risk, this is just as an example, darunavir from the Artemis trial. And to be honest, when we talk about lipids and risks and protease inhibitors, we very often talk about lopinavir and fosaprenovir, older PIs. Let's talk about darunavir. You see the difference. This is the rise in cholesterol in lopinavir-treated patients. This is total, this is HDL. If you take these, if you derive these values, this is baseline, this is the week 194 and 192 cholesterol level, and if you put that into an equation and assume that somebody is, let's say, 25 years old. Actually, this is not serious because you can just start the calculations at 30. So I just took the numbers for 30. And look at the additional risk that you induce by making these lipid elevations. This is calculated according to Framingham 2008. You see that the vast impact is age. And there's a little impact on the additional lipid increase due to darunavir in this case, and 2 nukes. In this case, you can't really calculate that because the baseline, the induced risk is greater than 31%. But you see, it's always the minor part of the risk. And there are other things that appear to be much more important. And this is somebody at the age of 65, and most of our people would probably be down here in this age range. So the risk depends on how you look at it. it's in the one-digit percentage, even sometimes in lower ages, it's less than 1% additional risk over 10 years of developing a cardiovascular event. Is this much or is this not much? You have to decide it yourself. For me, it would be, for the younger ages, an almost negligible aspect. Atazanavir, darunavir have been tested in a randomized comparison. The only difference they found was a little bit higher cholesterol levels in the fasted state with darunavir. The rest was identical. Almost identical. And what we're really interested in is not lipids. We're interested in cardiovascular events. And as Jean-Pierre Routy has already said, not all protease inhibitors are alike. We know from the early DAD analysis that lopinavir and indinavir and fosemprenavir later on stick out as having the risk. But what about efavirenz? We have similar lipid changes with efavirenz, but don't see the increased risk. So it's more than just lipids. And we should not keep our eyes only fixated on the lipids. The next piece of information, you already said that, is that atazanavir is not like the others. We don't have the data yet on darunavir. We have reasons to assume that it might not be terribly different from what we see with atazanavir, but it appears to be no increase of risk with cumulative duration of atazanavir exposure in the DAD study. So essentially we can say, doubtlessly, PIs induce lipid increases, with higher triglyceride increases on lopinavir and fosemprenavir, whatever this means, and a lower TCL to HDL ratio with ticagrelor that isn't used anymore anyway. We see that same with other drugs as well, efavirenz, elvitegravir, for example, so not all the new drugs are just better because they're new. And the reason behind the concerns is that they have been associated with an increased cardiovascular risk, as I've shown. But the magnitude of risk, if you ask a cardiologist in an editorial by Stein in the New England Journal, the magnitude of risk, however, is not high, as he said, especially as compared with the effects of other cardiovascular risk factors. And not all PIs are created equal. So the good thing about it is that if lipids get annoying to you as a physician, you can switch away if you have no resistance, if you have well-responding patients, you can switch away from a lipid non-friendly PI-based regimen to something else, and you can see the lipids will decrease. This is just one example of switching to a rilpivirine-containing regimen in the SPIRIT trial. So my conclusions would be drug-induced lipid elevations are no reason to avoid PIs in first-line ART, except for high-risk individuals. Some other drugs are not really much better. For some patients, there are even strong arguments for preferring a PI over other options. I haven't mentioned all those with primary resistance. Independent from the third drug choice, cardiovascular risk should be managed actively by lifestyle modifications, diet. I would encourage diet, but it's been said today already that it's very difficult to convince our patients to change the habits they've had for 40 years, plus statins, and most importantly, smoking cessation. And the good news is it's reversible. In case of lipid-related concerns and no resistance, there is the option of switching to a lipid-friendlier regimen later on. So I think there are better ways to reduce your cardiovascular risk than by not using a PI. So if you just go from an English-style breakfast to a bouillabaisse, you will already have done part of the job. Thank you very much.
Thank you very much. So it's now time to cast the second vote on this question. May we have the questions again, please?
On voudrait revoter sur la même question, s'il vous plaît.
Okay.
Okay.
Obviously, statisticians will say that it's not the same sample because we get at least 20 people more, 30. So here we are. The results, please. You are the winner, Hans. Thank you so much.
So the second debate is about art suspension. This morning we have a certain idea of art suspension, but now we call two persons from Milano. So did you have give your disclosure about team soccer AC Milano or Inter Milano? It's another question. So is art suspension never a good idea? We can say also, is art suspension always a bad idea? I call Giuseppe Tambusi from Milano to discuss.
We are going to vote first.
But before we vote, sorry.
So the question is art suspension never
a good idea?
A good idea? Yes, it's never a good idea. Or no, it can be a good idea. It's clear? So we can vote.
We have to find the same number, I hope.
So here we are. The results, please. So Giuseppe, you start with an advantage.
Giuseppe Tambus is for you.
Thank you. Thank you also for, yeah, sure. Thank you also for giving me the chance to be an easy winner in this play with Guido. And by the way, we are on the opposite side also in terms of soccer team. And so, my disclosure, and I start with this sentence, donec aliter provideatur. That in Latin means until other arrangements are provided. And this is a formula that used by the Catholic hierarchy when a strong rule has been established and can be eventually changed by the same hierarchy. And in 2006, after the publication of the SMART trial, a new strong rule has been established. This paper clearly shows that the suspension can be harmful for HIV-positive patients and cannot be used as a strategy in the treatment of HIV infection. And we cannot forget that in the same year, another important trial, the Trivacan study carried out by French group, NRS, show exactly the same data, the same results in another setting in Ivory Coast, and the conclusion were exactly the same. The CD4 guided structured treatment interruption strategy should not be recommended also in lower income countries. So after the publication of this paper, almost all the guidelines did change their indication, and all really strong recommended against treatment interruption. Recently released guidelines in Italy just open windows for patients treated during primary HIV infection, but generally speaking, all the guidelines are on the same line in terms of recommendation. So at the time I can leave the podium because the victory is already set, I guess. But I want to make another couple of points and to give Guido a chessmate and to put this victory very in a clear position. This is the printout. This is the print screen of the public website of INSIGHT. And as you can see, more than 60 papers have been published since 2006 coming from the original paper, and hundreds of presentations and posters have been published in a period of time. So I don't want to bother you with quoting different papers coming from the INSIGHT consortium, but rather try to put the situation, to see the situation from the patient side. In the clinic, when patients come and ask you usually many questions, but a couple of two are really important. The first one is how can decrease the risk of transmission to my partner? And the second one is how long I will survive. This second question is particularly make patients particularly anxious, particularly those that have a recent diagnosis of HIV infection, and so they are scared about the infection. They feel that their life can finish soon, and so we have to reinforce the message that their life can continue and they can have projects and go ahead with their and make their life very satisfactory. I start with very briefly with the first question, and I don't want to repeat what this morning Myron Cohen said already, but coming again to the Latin I started with, repetita juvant means sometimes some concept must be repeated to be to enter in the head of the people. And so I just want to say a couple of things. In 2008, the Swiss statement was released, and as you remember, this statement raised a lot of perplexities because it was difficult to understand how to apply this strategy in other countries. As a joke in Italy, we say that one is very precise is a Switzerland, and when something works very well, works like a Swiss watch. But in Italy, we are not like that, probably even in France or Spain. So we cannot apply this statement in everywhere. But patients ask us, I heard that in Switzerland they do in different way something. And so what is the position of the physician? And so we have to say them that they have to continue the therapy, they don't stop therapy, they have to be adherent to the therapy, and doing that, the risk of transmission will be decreased in a significant way. So recently I put this slide on my presentation because it's the huge sample size in China. They study retrospectively nearly 40,000 couples and published the result in the Lancet, and the results were always the same. The continuous art and the therapy is protective in terms of transmission of the infection. And there are some discussion about the sustainability, if this is applicable also among men who have sex with men. But the last Cochrane review of this argument, the author conclusions state that art is a potent intervention for prevention of HIV in discordant couples. So the rule is that the therapy must be continued and people must be adherent to therapy. The second issue is at least as important as the first one. In 2008, this paper was published with a big collaborative cohort, and this paper refers to the data collected between 1996 and 2005. And still, at the end, the average number of years remaining to believe at age 20 years was about 2/3 of that general population in these countries. But what did happen in the last year? Thanks to the two presentations that you heard, we heard before, it was described the new drugs, that the availability of the new drugs with less toxicity, very easy to take. So the progress of therapy plays an important role in terms of make the therapy much more acceptable, less toxic, and so that can be continued instead of interrupted. This year, the UK collaborative HIV cohort published this paper showing that for those patients who have viral load below the limit of detection and CD4 above 350, the life expectancy is comparable to the life expectancy of general population in UK. And at the beginning of this year, we did a similar work, and we published a large study on nearly 10,000 people following 5 centers in the north part of Italy. And the bottom line is that for those patients who have satisfactory immune reconstitution with CD4 above 500, the life expectancy is comparable to the general population. And this can be, this result can be reached in those patients that are under therapy, that they do not suspend therapy. So another good information is that this is this can applicable not only in country like France or Italy or UK, but also in country with a low income, such as, for example, Uganda or South Africa, and this is the paper that is published in the last year, and the conclusion is that South African HIV-positive adults can have near normal life expectancy, provided that they start hard before their CD4 drops below 200 cells. And so there is a huge amount of data, information we have that strongly indicate and suggest that the therapy must be done, must be continued, and therapy interruption are not anymore safe approach for the treatment of HIV infection. So I come back to the original paper, and my conclusion is very simple. Heart suspension is never a good idea until other arrangements are provided. Thank you.
Thank you. So Giuseppe Tambusi don't suspend antiretroviral treatment, and now I call Guido Poli from Milan also to present the opposite way. Thank you. We worked a second time.
Okay, first of all, thank you very much for this opportunity to challenge Giuseppe on this very tantalizing issue. And two statements here. First of all, the only conflict of interest that I should declare is that although I have an MD and I have been involved also in the design of some clinical trials such as the ESPRIT, I don't see patients. So my approach is naturally that of a researcher, tending to see more of the, let's say, beyond the practical approach. The second statement regards the question of the chairman, and I would like to remind that my team, Inter, will play Europe League next year, so I don't know about other teams from Milan. I'm not aware of those. So clearly, what I'm being asked here to do is an unbalanced challenge, and there is no reference to our physical statutes here. But clearly, there would be no chance for the little guy that I am representing here to win over the big guy, the challenge in a frontal confrontation. Therefore, what I will do is try to go around it, and just to make you thinking a little bit. Also, a lot of other speeches at this conference here have really stimulated our brain. And the bottom line that I will rephrase at the very end of my talk is that although a lot of evidence tend to go in the same direction, sometimes it's a good idea to think out of the box and see other direction. So, and to do this, as I mentioned, I'll use three examples. One, if it is very famous to you, very familiar to you, it has been already reminded by Mark Weinberg, Stefano Vella, and many others, and regards the early days, glorious days of discovery of antiretrovirals and with the rise and fall of the AZT monotherapy. Okay. At least people of my age remember how good life was for students in medicine to study the chapter of antivirals in the 70s, because basically there were no antivirals. The only antivirals known was amantadine, rimantadine, ribavirin sometimes, interferon that, like me, was born in 1957, and there was also some described off-targets of some antibiotics such as tetracyclines. That's it. Easy life for students. Less of a good news for the patient. And actually the discovery of AZT, and you all remember that this was a sort of an orphan drug that was left over and is sent by Barros and Wellcome, that then became GSK to the NCI and NIH, and Mitsui and Broder testing this demonstrated a very potent effective activity. So the first real antiretroviral, we'd say even probably one of the very first antiviral in general. And was already remembered the New England Journal of Paper 1986, very exciting. But then the French-UK alliance, known as the Concord studies, demonstrated that the effect of AZT monotherapy was short-term lived, and secondly, induced drug resistance. So clearly the monotherapy became, it took, as Stefano Vella reminded, a lot of time to go over that. But essentially was declared not a feasible, not an ethical to some point approach to be proposed to individuals at the time. However, the point here that I'm trying to stimulate you is, so based on the knowledge of the time, the logical consequence should have been dropping completely the AZT monotherapy approach. But then something else happened. It was the early trial that started a new line in which even the monotherapy that was bad for adults was a very good news in stopping, at least not stopping, but at least retarding and delaying and preventing in some case the vertical transmission from mother to child. So something that did not work in a, let's say, common setting could work in a special setting. Although it's not my topic, and I think Marc Girard will discuss this later on, and already did before, something similar is happening in the vaccine world, when the combination of two vaccine candidates who individually failed, putting together, demonstrate the only trial that made some relative progress, the RV144 trial. Just to say that, and again, this is a returning theme, that when we think that we have figured out all the variables of the system, something else pops out and make us thinking that perhaps the reality in this case is the patients and the epidemics, is not totally figured out. So the example 2 follows the same philosophy, that there are exceptions to the rule.
And in this case, I'm talking about specifically HIV infection, and it is very clear that about 90 to 95 of HIV-infected individuals more or less follow in the same, let's call it relatively homogeneous category. But then we learn that about 2–3% of individuals are born for a number of factors with a long-term non-progressing attitude, which means that they control spontaneously their, let's say, immune system or the CD4 cell count for decades now. Very few, but still they exist there. Later on, and the French have given a great contribution in this field, we discovered there is another subset of individuals that are equally relatively lucky, so to speak, because they control spontaneously their viremia levels by CTL, and probably also by other factors. And Domenico Stagliolo did a very nice study, demonstrated there is a small crossover of the two phenotypes. So very few people have both the features of LTMP and elite. So we can call them, unquote, lucky phenotypes. So if you have it, you're relatively resistant to the progression of disease, although you're not protected from getting infection. So in the essence, what all the studies in this area demonstrated, that one clear-cut associated factor is to inherit, to be heterozygous for CCR5 delta 32. If you're homozygous, you're virtually protected from infection. And then to inherit good HLA or MHC genotypes, namely B27 and B57 are good. And again, the French, Brigitte Autran, Buzz Walker in the States, many other groups, clearly demonstrated these are the good phenotypes. But also bad phenotypes, such as B35, okay? So based on this very solid knowledge, a lot of studies, we also ran a European collaborative studies on this, we can say, well, perhaps we could foresee to stop art for a number of reasons in those with have an inherited lucky phenotype, or lucky genotype, if you prefer. But then, if we had pursued straightly this logic, we would have never discovered what has been discovered, again, by the French investigator about the Visconti cohort of post-treatment controller, okay? So in a very elegant study with Christine Rosieux and many others that probably some of you are here in the study, they published this very provocative paper that again reversed a lot of the things that we thought we knew about control. Because these people, unlike the elite controller that you can see as HIC, they clearly experience loss of CD4 cell count, high viremia level. They do not have the good HLA genes, so to speak, but they actually enrich in the B35, which is the bad HLA gene. So again, when we thought that we had figured out everything about genetic determining resistance to HIV disease progression, here comes a very provocative studies that says that probably not everything is there. And again, HIV DNA content that is either stable or even decreases. Third and last example before my conclusion is look for the non-obvious. Okay, thinking out of the box if you wish. And I want to draw your attention, I'll go very briefly, on a very recently published paper by Chuck Rinaldo with Giovanni Rappocciolo, who's an Italian investigator, about a sort of an unsuspected or low-studied or relationship between cholesterol metabolism and the long-term non-progressor phenotype, okay? And essentially what they've seen, and again the paper is very interesting, that two out of the 3 antigen-presenting cells, such as the dendritic cell and B lymphocyte, fail when they are isolated from long-term non-progressor. They fail to trans-infect the T cells in vitro. You can see the data here very quickly. And essentially, this feature is linked specifically to a depletion or a natural depauperation of their cholesterol level, as well as to an increased expression of the transporter of the cholesterol, the ABAC1 cholesterol. This applies to dendritic cells, it applies to B cell, but that does not apply to CD4 T cells. So it's a selective effect. It's a selective effect that seems to be protected for some reason, or at least associated with it. And it is an inherited character, by the way. And this was known already. If you deplete by beta-cyclodextrin cholesterol, indeed, you prevent transmission. So again, an association that may inspire a new thing. And the last point I will make and there was a link also will be studied, is a very interesting editorial that just came out a couple of weeks ago, actually 1 week ago in Science, is the idea to hunt for the missing genes, because everybody, in a figurative sense, goes for the genes linked to disease, but who goes for the genes that help for the healthy situation? In other words, the idea that there could be genes dispensable for a general healthy condition, and please note that CCR5 has been a sort of an instrumental in this. But again, it has been calculated that each of us carry on average 20 knockout of genes, and when you extend this analysis, according to the study, to which genes are also inhabilitating in terms of expression, each of us carry at least 100 genes in our own genome that are essentially not expressed. Yet, most of us conduct a healthy life. So the idea, and indeed, by pursuing this approach, essentially we also find out that another of these dispensable genes is PCSK9, which is a new enzyme linked to the LDL metabolism, and indeed there are new drugs that are targeting, in addition to statins, this drug metabolism, this cholesterol metabolism receptor. So it's a new thinking. And with this, I will move to my conclusion, and clearly there is no question about that our discovery has been an incredible success for science and for the life of HIV-infected individuals, and this remains. However, the limitation that has been very well detailed in this meeting of the usage of art in terms of side effects, of the ability to export art in low-income countries still remains. And let's remind the lesson that not all humans are created equal, and that by studying human diversity, we may improve both the use of current art regimens and, more importantly, discover novel approach to complement the art success. And having said so, this is my French, merci beaucoup, and I look forward to your vote.
Thank you. So now you have to vote, and we will see if Guido Poli change your idea on suspension to art. Let's go quickly. There is a amelioration of the score of Guido Poli. The discussion was very interesting, I think. But the tendency is the same.
So we can move now to the last debate. And we already heard a lot about the feasibility or non-feasibility of, I would say it's not in the title, but the question will concern a preventive vaccine. And the question is a preventive HIV vaccine achievable? So, Marc Girard, there are two people from Pasteur Institute and 2 points of view to defend. Marc Girard will defend the pro, and Marie-Lise Goujon will defend the cons. So First, you cast your vote, please.
So the question is, can we eventually develop an efficacious HIV vaccine? And my answer is yes, we can. First, no conflict of interest.
Yet.
Marche pas?
But because people are still voting and
Qu'est-ce qu'il faut faire?
we can wait 10 seconds more. So, make up your mind, please.
Can somebody help?
Okay, so you are starting with the advantage.
Oh, sorry. Excuse me.
54 people think that you can.
Oui. Je ne comprenais pas qu'elle n'y soit pas. D'accord. Ils sont en train de voter. Alors.
Within the next century.
Can I go? Yeah, so again, the question was, can we eventually develop an HIV vaccine? And the answer is, yes, we can. Sorry. I think we all agree that so far, to the exception of the RV144 trial, there has been no clinical evidence in favor of the efficacy of a vaccine to prevent HIV infection in humans. And classical vaccine approaches which elicit neutralizing antibodies are aware and will be doomed to failure because of the virus variability, the number of circulating virus strains, and the ease with which neutralization escape mutation can arise, which explain the failure of the VAX-003 and 004 trials. And the vector or DNA-based vaccine regimens or the prime boost regimens using these vectors have also been a failure to date, probably because the T-cell responses which were induced were too weak, and probably also because there was not enough of an activation of T memory cells. However, as I outlined this morning, there are several new vaccine approaches which are worth considering and which give us hope that we will be able eventually to have an efficacious vaccine. So let me remind you quickly that one of the first but difficult approaches is that of the broadly neutralizing antibodies, which arise in a minority of HIV patients after a few years of infection, but which neutralize cross-clade 70 to 90% of known HIV strains. They've been tested in animal models, whether mice or monkeys, and they were remarkably effective. And if we had a vaccine able to elicit a broadly neutralizing antibody response, I think that all of us would be very happy about it. There would be no problem of efficacy that we can think of at this time. The problem, however, is that we don't have the appropriate immunogen, so we do not know how to elicit this broadly neutralizing antibody response, and probably it'll be very difficult because of the way the B cell maturation takes place to provide the synthesis of these antibodies. And that's where the interesting development of vector immunoprophylaxis approach, which was described twice this morning already, so I won't go into details, using a vector like the adenovirus-associated virus, AAV, that expresses the heavy and light chains of a broadly neutralizing monoclonal antibody, such as VRC01, for example, or VRC07. The approach has been done in monkeys and in mice, and so far it's been remarkable because it's totally protective, because the expression of the AAV vector is very long-lasting, lifelong, for example, in the humanized mice. So it's a very interesting strategy to be considered for the future. The second important approach results from the RV144 trial, and I will remind you that protection in this trial was weak at the outcome 4 years later, but was quite sufficient, 61% after 1 year after vaccination. And it waned progressively with time. There was no CTLs, no neutralizing antibody response that would correlate with protection, and that led to the identification of ADCC and perhaps ADCVI as the markers for protection. This gives us a totally new view, a totally new approach to making an efficacious vaccine. Then I will remind you that this morning we had, I mentioned briefly the results obtained with Morgan Bumsell with using GP41 on virosomes that would provide the induction of secretory IgAs, which blocked transcytosis of the virus across monocellular epithelium, such as that of the cervix or that of the rectum. And finally, I'd like to also remind you of the Louis Picker's approach using recombinant rhesus CMV vector that expressed the SIV genome, or most of it, and which allowed 50% of the animals to be totally protected from infection with a SIV rectal challenge, but not immediately, but after a series of blip arising over about 1 year duration. But the important thing was the elimination of the virus reservoir at the end and the clearing of infection. So the question would be whether we can find an appropriate vector to extend these results to humans. So I would say that, again, there is a lot of hope in these things, and the most difficult perhaps is the eliciting the long-lasting T effector memory cell responses that are able to eliminate the virus reservoir. The difficult part will be to elicit a broadly neutralizing antibody response. Oops, what did I do? Sorry. I pressed the wrong button. The second one would be, as I said, eliciting a broadly neutralizing antibody response, but the VIP approach will certainly be a way to turn around the difficulty, and it should be tested as soon as possible in humans. Improving the RV144 trial is an easy approach, and by changing the vector, by changing the adjuvant, by adding a new additional booster immunization with a glycoprotein, etc. And this should be tested as soon as possible too. Last but not least, the development of a GP41 virosome vaccine might also be of great interest in the future. So, in conclusion, in complete honesty, I will say that I'm sorry that I and nobody knows when will an efficacious vaccine eventually be developed. But there are many new paths open for exploration that might lead to an efficacious vaccine. And therefore, the quotes from Winston Churchill on what is success is going from failure to failure with undiminished enthusiasm. I couldn't resist also quoting Niels Bohr, a great man, who once said that prevision is difficult, especially about the future. But I personally completely trust the future, and I think we all should do so. Thank you.
To cast your last vote, please. Congratulations, Marie. So it's always funny to see the results of these votes. And we're expecting to see the results concerning Europe this Sunday. Thank you for being here until this last session.